Assalamu alaikum, the clinical day. Your role is the senior house officer in the medical clinic. Scenario, Mrs. Sophia Adam, 35 years, referred to you with complaint of eye puffiness, blood pressure, vitals, blood pressure 145 over 90, heart pulse rate 75, temperature 36.6. Your task to sit with Mrs. Sophia, examine her, and address her concerns. You ready?
Yes.
Yeah, here you go.
Hello.
Yes.
My name is Dr. Ahmed, one of treating doctor in the clinic today. May I confirm that you are Mrs. Sophia, 35 years old?
Yes, I am.
Mrs. Sophia, we are here today to discuss some issues related to your health and examine you and address your concern. Is it okay?
Sure, doctor.
It came to my knowledge that you have been troubling with eye puffiness. Can you tell me more about this?
Yeah, doctor. I notice this happen frequently last year. It's comes and goes. I don't know what's happening, doctor.
How many times this happened before?
It happens three times.
Did you seek any medical advice?
No, doctor, because I put some ice and it's resolved.
So is resolved spontaneously with only eyes, no other medicine.
No,
Okay. Uh, for 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 the last time, when did it start exactly?
it was last month.
From start until now, is it increase, decrease, or the same?
Almost the same, doctor.
Is it related to any specific time of the day?
No, doctor, I didn't notice.
Have you noticed anything make it worse?
I didn't notice, doctor. Like what?
Like mainly in the morning or doing staying at bed for a
No,
long
it's not
time?
related. Not related, doctor.
Okay, so is it associated with any pain, any part in your body?
Sometimes I have tummy pain.
Since when?
The same, doctor, same duration.
Okay, we'll come in a minute. So, any lower limb swelling
Yeah, doctor, I notice also swelling in the legs.
up to where?
Up to ankle.
If you press on it, does it leave mark?
Yeah, it leaves mark.
What about your waterwork? Is it about color,
Same, doctor, no change.
amount,
It's almost same, doctor, no change.
any frothy urine,
No,
any blood in your waterwork before or now?
no, doctor.
Any pain with your waterwork?
I have some pain, doctor. It's on and off, and I pass the stones sometimes.
Mhm. Okay, so any weight changes,
No, doctor, almost same.
any loss or bumps anywhere in your body,
No,
any neck swelling,
no, doctor.
any high body temperature?
No,
Anyone comment that you become paler than before?
no, doctor.
Any feeling tired?
No.
Miss Sophia, do you have any past medical illness should be aware of?
Yes, I have diagnosed with. I have been diagnosed with hypertension
Since when?
since 3 years.
Can you please give me your full medication list?
Yes, I take amlodipine and thiazide.
Okay. Do you have any past family history of similar problem?
My father was hypertensive, doctor.
Any family other family history of note?
My mother was diabetic.
And your father at which age diagnosed with high blood pressure?
He was as early age 40s.
Okay. Okay. So, does your blood pressure controlled?
Sometimes, doctor, when I have stress, it's becoming high, but
Mm-hmm.
most of the time it's controlled.
Okay. So, any joint pain,
No,
skin rash,
no,
any difficulty getting up from the chair,
no,
any cough,
no, doctor.
any cough no blood,
No,
any chest pain,
no,
any difficulty of breathing.
no.
Regarding this tummy pain, can you tell me the site exactly?
It's all over, doctor. It's not localized. All over.
Any heart pain sensation?
No,
Okay. So, any change in your bowel habit
no, doctor.
and difficulty of
Regular.
swallowing?
Sometimes, doctor, when I have like difficult swallowing because of it comes and goes also with this swelling in my eyes.
Can you tell me more about this difficulty of swallowing? Is it started with hard food or liquid also?
It's not related to food, doctor. It's related to my tongue become like swollen.
Mm-hmm. Okay. So, well, well, Miss Sophia. So, and no change in your power habit at all.
No, doctor.
What about your mood?
My mood is okay.
Any headache?
When my blood pressure is high, I feel some headaches.
Is this headache increased by sneezing or coughing?
No, doctor.
Okay. Any vision problem at all?
No.
Okay. So, Miss Sophia, can ask you a private question if you don't mind.
Sure, doctor.
Are you married?
Yes, I have a partner.
Okay. So, what about your period? Is it irregular?
Yeah, doctor. It's regular.
What about amount?
It's regular, doctor. No change.
Are you using any birth controlling pills?
No.
Do you have kids?
Yeah, doctor.
What is the age of youngest one?
He's 3 years.
Okay. So, Miss Sophia, but I mean, I have another question. So, you started this, you have been diagnosed with high blood pressure 3 years ago.
Yes.
From the start, can you tell me, does your doctor start with one or two medicine?
It was started with one. Later on, he added the other one for. He told me it's water pills.
Water pill. And regarding this AC inhibitor, when this is exactly introduced? You started at what time?
What is inhibitor, doctor? You mean I cannot
I mean,
understand.
yes, I'm sorry for that. I mean, you mentioned you are taking two medicine.
Yeah.
Uh,
Uh,
amlodipine.
amlodipine and
Mm-hmm.
thiazide.
Thiazide. Any recent change in the dose?
No, doctor.
Okay. Miss Sophie, do you have any allergy for any medicine?
No,
Okay. What's your job?
I'm a cashier.
And how does this affect your job and daily activity?
Yeah, I'm worried, doctor, to be happened at work. It's
Mhm,
embarrassing.
mhm. Okay, I'm sorry about what you have been through. I will help you as much as I can. Do you smoke?
Yes, doctor.
How many cigarettes? For how long?
5 cigarettes for 5 years. Since 5 years.
Okay, Ms. Sophia, I advise you to stop smoking because it's bad for your health. And if you would like, I refer you to smoking cessation clinic.
Okay, doctor.
Do you drink alcohol?
Especially and occasionally, doctor. Not.
Do you drive?
Yeah.
Is this problem affect your driving by any way?
No, doctor.
Okay, can I examine you?
Yeah, sure.
Okay, so I will start with this eye examination about visual field,
Yes, visual acuity first, right?
visual acuity.
Yeah, she can see your fingers well and chart well. It's not impaired.
Okay. Then I would like to examine for the abdomen, looking for tenderness and organomegaly.
No organomegaly, no tenderness.
Okay. Then I would for this. Okay. So cardiovascular examination, first and second heart sound,
Normal,
any murmurs.
no murmurs,
Okay. Then lung field for anaphasic crepitation.
no crackles.
Then I would like to examine for the lower limbs. I will ask first for tenderness and then press over the medial malleolus.
No swelling now, no edema now.
No edema now. Okay, so then for hand examination, any abnormal changes in the nail,
No,
any tremor.
no tremors.
Okay, eye exam regarding the eye examination, any pallor or jaundice.
No pallor, no jaundice.
Mouth examination, I would like to examine for the tongue. Is it enlarged or normal?
Now is okay, nothing.
Okay. Then okay, what's your concern, Miss Sophia?
What I have, doctor? Why this swelling in my eyes and in my face comes and goes?
Okay, Miss Sophia, I highly appreciate your concern. From what you said to me, and after I examine you, I'm concerned that you might have a condition called hereditary angioedema. It's a medical term for medical condition in which there is a deficient of important protein, and this leading to buildup of substance, given the symptom that you have. And what we need to do now is to do some blood test and imaging to confirm our diagnosis and to exclude others. Then we will sit together to discuss a proper plan of management, which usually we're going to take care by a group of specialists in form of we need to involve the heart doctor to control your blood pressure, and we need mean kidney doctor and defense system, I mean an allergy doctor. Do you have another concern?
Yeah, doctor. Is it serious, doctor? And why my tongue also being swollen like what I had before?
I'm so sorry to tell you that it is serious if left untreated and might affect your breathing, and this can lead to serious problem. And the swallowing of your tongue, it's a part of your problem. That's what it's a part of your problem of this deficiency of important protein.
Okay, doctor, you mentioned I cannot understand why I have this disease, doctor.
Actually, it's a familiar disease sometimes. That means it's run in family. Uh, for that is that's mean sometimes, and sometimes might be due to of some allergen. However, to be honest, in your case, I could not appreciate any one of these triggers.
2 minutes left. Yes, doctor. My father didn't have it at all in his life.
Mhm, mhm. I highly appreciate concern, Miss Sophia. This, yes, in your case, might be a new. I mean, this might be due in your old family might pass unnoticed, and this might be just new change in your codes. I mean, what is called gene.
What about my kids, doctor? They might have this disease.
Yes, this is the familiar disease actually, and 50% of your kids. I'm so sorry to tell you that 50%, your kids have a 50% chance to have this disease. As we
You,
have discussed, this is a familiar disease.
so you mean half of my kids will have the disease?
Not your half your disease. I mean your disease. Your kids have 50% chance to have the disease.
All of them, right?
Yes.
So half of my kids will have the disease, and the other half will be clear, right?
Regarding this mode of the way this disease transmitted from from the father to his kids. Yes, this following, and 50% of your kids have the chances to have this disease.
Okay, doctor.
Okay, thank you for talking to me, Miss Sophia. Do you have any other concern for me?
Will you admit me, doctor?
Well, in your case now, after assessing you, we need to assess you again if you have
Okay, time
there
is
is
up.
okay.
Okay, thank you, Dr. Minam. Let's start clinical examiner question. Present your case, please.
This is a 35 years old lady present with a 1 year history of on and off preorbital swelling and tongue swelling and lower limb swelling. Apart from that, she has past his medical background of hypertension diagnosed 3 years ago in amlodipine and thiazide diuretics. She has a past medical history of hypertension regarding her father, which is diagnosed in early age, and her mother with diabetes. In the examination, I could not appreciate any abnormal finding apart from the high blood pressure, which is 145 over 90.
Okay,
So, my summary of my finding features suggestive of hereditary angioedema.
okay. Other differential. Can you give me other differential diagnosis?
The other differential could be uh, renal failure for other differential. Could
Okay,
be, hypertensive nephropathy.
okay,
Um, in such case, could be a cardiac cause. However, I could not appreciate any abnormal finding in the cardiovascular. Could be heart failure and could be liver failure. However, I could not appreciate any other features suggestive of liver failure.
okay. You mentioned to the patient you will admit her. Does she need?
Um, I could not appreciate any signs suggestive of admission.
So, how you will, what you will do with this patient? How you approach?
For approach, I will do a routine investigation.
Okay, so it will be not as emergency, right?
For now, there is no any emergency. There is no
Okay,
shortness of breath. There is no tongue
perfect,
swelling. Yes.
perfect. So what you will do? Investigation,
Apart
basic.
from
Yes, go
apart
ahead.
from routine investigation, would like to do complete blood count, renal function test, and electrolytes, liver function test, and enzyme inflammatory markers, and I would like to do genetic test for. Actually, I forgot the name of the test that confirming hereditary angioedema.
You mean the enzyme?
Yes, enzyme.
Okay. You mentioned hereditary angioedema. What other angioedema you know?
You mean
Yeah. Yes.
allergic angioedema?
Perfect. What else?
And that's it.
Okay. You don't.
Drug.
Yes. Perfect. What else? Okay. What common cause? What common drug can cause angioedema?
Angiotensin converting enzyme inhibitor.
And any history for this in the patient?
No, she's only take. I'm not sure amlodipine if can trigger. I'm not sure actually.
What that amlodipine mechanism of action?
Calcium channel blocker
And it can cause angioedema, facial angioedema, or what?
can cause lower limb swelling mainly.
Ankle, yes, ankle swelling. Okay. How you treat this patient? How you manage?
Okay. First of all, education and the counseling of the patient about heart disease. and to stop smoking and refer her to smoking cessation clinic. And
Perfect.
the treatment will be by multidisciplinary team in form of cardiologist, nephrologist, and immunologist, and uh, yes, and social worker.
Okay. What if in between attack and what during attack? Pharmacological therapy.
Okay, for in during the attack, secure the airways, ABC approach,
Mm-hmm.
and for for the prophylaxis.
Yes.
Okay, for the prophylaxis, can give a steroid
Okay.
and acetylzolamide. مش acetylzolamide يا ربي هو كان اسمه.
Okay. And in between attack, or let's say, what's the medication of choice for hereditary angioedema, assuming that this patient is having hereditary angioedema?
Okay, the three. To be honest, I forget it.
Okay. Okay. Fair enough. Time is up. Thank you, Dr. Abdul. Well done. But I guess you didn't read this topic recently, right?
Yes,
Or you
long
forget.
time.
Yes,
Yes.
exactly. Sometime, this case we did it before, but sometimes such kind of topic should be refreshed every now and then because it's single topic by itself. I mean, it's a differential for itself, the angioedema. And
Mm,
yeah, you have to give the all cause of angioedema as a differential. It will not be overlapped with others. You put it overlapped with kidney and heart failure, but it's not. It's something. If you analyze well, you will reach it's in the face and the eye, and sometimes the lips, the tongue. But I guess you didn't analyze the complaint well. You jump direct because you put in your mind it's renal cause. It's a tricky. The complaint is a tricky one. It's not only buffness in the eye. It's facial swelling and buffness of the eye. If you ask me, I could tell you that. Anyway, the case is not hereditary because the patient family were okay. So the fourth type, which is by exclusion, will be the diagnosis. What are the types? You can enumerate or anyone can say.
Acquired,
Alaikum assalam.
acquired one.
Hello, Assalamu alaikum. There
Walaikum
will
assalam.
allergic,
Yes, yes, go
allergic
ahead.
idiopathic. Number
Acquired.
one,
Hello?
number two, drug induced.
No, no,
Number
Dr. Azhar, your sound is so muffled. If you can raise it, please. Dr. Azhar?
yes, yes,
مازن
yes.
ممكن الاجوبه يا مازن ممكن كده الاجوبه يا مازن مازن
Hello.
Yes.
مازن دي حضرتك من
Yes, Dr. Basam.
Yeah, go ahead, Dr. Azhar. Yes.
So there may be allergic or
Okay.
idiopathic angioedema.
Excellent.
Then drug induced, mostly it is due
Perfect.
to is inhibitor. Then if
Yes.
the family history positive, then we can say it is
Perfect.
hereditary angioedema. And the
So,
treatment of the hereditary angioedema will be C1 inhibitor
yes, exactly.
concentration and beta 2 bradykinin beta 2 receptor antagonist like a tie band. And
Yeah.
then in between for the prophylaxis, if it is hereditary, this is not a
Yes.
case of hereditary, this is idiopathic, because we could
Perfect.
not find any cause. And
Perfect. Yes, exactly.
Dr. Abdul Minim, I think he also forgot to ask about rash and
No, no, he asked about Rush. He asked about Rush.
any allergy. He only asked any allergy to any drug. So
Yes.
question should be, so for the prevention, we can give danazole
Yeah,
tranexamic acid.
perfect. Yes, this is for
And if it
hereditary.
is idiopathic, if it is idiopathic or
Okay.
allergic, then we can go for the ABCD, antihistamine, steroid, then epinephrine pen, and then uh, uh, auto injector epinephrine we can use.
Okay, and for
Epinephrine we will never use in the hereditary
exactly, yes. And for
because
the drug induced,
we will stop the drug
yeah,
and we
stop the
will
offending
involve the
drug.
cardiologist to replace it with other drug.
Yes, exactly. Okay, thank you, Dr. Azhar.
Welcome.
Yeah, thank you. And now you remember the types, Dr. Abdulmenaim?
Yes, yes, thank you.
So they are four, okay? And you have to
Because
start in
sorry,
a
Dr. Basu, one
stepwise.
minute.
Yeah, yeah.
One. Recently, this case came in the exam, and one
Hmm.
examiner asked, it was a case of idiopathic. He said,
Yes.
no, sorry, it was a case of hereditary. He
Yeah.
asked, will you use epinephrine in hereditary?
No rule.
And those
Mhm.
candidates who told had, I will use epinephrine, I think I got this remarks that, uh, well, okay, he was pinched very badly.
Yeah, yeah. No rule in the EpiPen with with
Uh-huh.
the hereditary type.
Yes, yes.
Okay. Okay. So the types, Dr. Abdulmenaim, you can say acquired and congenital, and congenital will be like hereditary one, and the others are acquired. Sometime and some people will prefer to divide like this, but make it four categories better, and you will know stepwise manner to diagnose and to differentiate. So first of all, with the family history, if there is family history of the same condition, father or mother, it will be mostly hereditary angioedema. The same condition, of course. Okay, so it's because of because it is autosomal dominant. But if no family history, you will ask about allergy, and the allergy not only for drug, even food, even sometimes bite. You can ask about any bite, a snake bite or any mosquito or fly. Sometimes it could be like this, or even ant. You have to ask about any exposure to, or any swelling due to bite or any food allergy. It's not only drug allergy. If you ruled it out, you will have the rest, which are drug induced, and the last one is idiopathic. The drug induced, definitely, as you said, it will be related to ACE inhibitor, and amlodipine is calcium channel blocker. So don't mix, okay?
Can I add
And
something?
if you rule out all of them, the remaining one will be idiopathic. And the idiopathic trigger, it's happening with infection or some stress in her life. It might be the trigger. Clear
Can
now,
I add
Dr.
something?
Admin? Yes, yes, sure. But please, there is some
I
echo.
think yes. I
Dr.
think Dr. Basim, there is a video for Dr. Salah about facial swelling, and he add there is a type called acquired angioedema. Usually come
Yes,
with SLE and connective tissue disease and also lymphoma. So we have five types of angioedema. Also, there is acquired with so
with
we
other
should ask about yes should
mm,
ask about also joint
other
pain and
connective tissue disease. Yeah. Anyway, you will have positive system review finding.
yes.
Yeah. Okay. Thank you, Dr. Shayman.
What is the cause of stone in such patient?
Thiazide. It's not. It's distractor, so don't go with it.
Mhm.
Okay.
Okay.
Diuretics.
And also the Dr. اللي هو الليمبيديما for the amlodipine.
Yes,
Yeah,
yes.
it happened with amlodipine ankle edema, but
Yes.
Yes
it's
يعني this is distractor also.
distractor. Yes, but if he focused on the main complaint, it was buffness in the eye, and I told him myself I got some dysphagia because of lip tongue swelling. You have to explore others. I mean the other parts in the face, facial swelling, lip swelling, and also the buffness of the eye. she had the attack with these all together. But of course, if I said it in the complaint, you will know the case. I put it like tricky one to distract you away from the angioedema. And that's why you are trapped. You thought about renal because of the buffness of the eye, cardiac buffness of the eye, but it's generalized facial swelling, not only buffness of the eye. Okay, and no frothiness in the urine. You got it, Dr. Abdulmana.
Yes, yes,
Yeah, but by this way, you will never forget it again.
definitely.
Yeah. So please read about the topic today. It comes in the exam, by the way, angioedema, and they are, as I said, differential to each other. So whenever you have it, you can say it together. Sometimes the chronic abdominal pain, on and off abdominal pain, comes as acute intermittent porphyria, angioedema. It's a differential for chronic abdominal pain. But as the facial swelling, it's clear angioedema. This is definition. This is the definition of angioedema: the face or facial swelling, along with the eye and tongue and lips. Sometimes also with hands and legs swelling or edema, according to the exposure and according to the type. But it's like reaction. But in hereditary type, it's different somehow by the family history and the defect in C1 inhibitor. Okay, and bradykinase release, and this is the cascade of it. But in this type, it's like a reaction due to stress, and I mean in the idiopathic. So you have to approach by this way. First, the family history, but after analysis of the complaint, you didn't analyze it well. You didn't ask which eye. Suppose to ask which eye, I will tell you both eyes, but you didn't even ask. Okay, analyze it first, then go to the differential. If you know it well from the start, you will know it's angioedema. If you ask me the lips, the tongue, but you jump from the eye to the kidney, then the legs swelling. So you put something in your mind, and you follow your mind only. You didn't think about others. Okay, this is for the differential. I also trapped you in the point of autosomal dominant. I want you to explain it again, because what you mentioned in the explanation will be wrong. You said 50% of your kids, right, Dr. Abdulmana?
Each one of her kids
Yes, I ask
have
you how many you didn't explain it well. Each kid have
50%.
50% possibility to have the disease. So be
Yes.
clear that, because the concern, your answer on the concern will be considered as a judged by the examiner. Okay.
Mhm.
This is for
Okay.
the mode of inheritance, so 50% autosomal dominant. Let's go to the examination. When you do examination of part, don't go back to it. And always, I said, go systematic. From the hand, vital chart, blood pressure, if you want proximal myopathy. When you finish the hand, don't go back to the hand. When you finish the eye, don't go back to the eye. You ask for the eye acuity, then you went down to the abdomen, then you went up to the eye again, which is
Mhm.
also not the way the examiner prefer. They might minus you in the physical examination at all. If Dr. Mahmoud here, he will give you unsatisfactory because he's tough exam.
Very tough, very tough.
Sure, Dr. Basim. So, Dr.
Yeah,
Basim,
see,
what
he's waiting for you.
I am waiting. So, Dr. Basim, what's the differential diagnosis in this case? First, idiopathic, yes?
Yes, yes, of course, idiopathic.
And what
Because
else?
idiopathic, drug induced, all types of angioedema you can mention, but you will
Okay.
say against that is that, against that
Uh-huh.
is this.
Okay. Yes, Dr. Basim.
Okay.
Thank you.
So we can give Dr. Abdulmenaim marks, Dr. Mahmoud.
Sorry, Dr.
You
Adnan, but
you want?
but yes, he felt in concern. He told me I am. It is a familial disease. It is not familial.
Okay, so because misdiagnosis, but he answered the concern, so it will not be for the concern. It will be for the clinical judgment.
Yes, borderline, Dr. Basim.
In what?
in concern.
Concern borderline, yes. Okay.
Yes.
Because also the clear answer of familial, he didn't give me clear. I asked him definitely how much, please explain it. And he gave me again the same sentence. So don't try to repeat something if you are not explaining it well. You explain it, then you repeat it again. If all your kids will be having 50% of, but I ask you how many or what you mean, doctor. So try to be more specific. Every kid have a possibility of 50% to have the disease. Clearly, this is for any autosomal dominant. What about autosomal recessive? Dr. Abdul Menai.
Yeah, 50% of his kids will have the disease.
Autosomal recessive.
Autosomal recessive. 25%, right?
Perfect, yes, 25%. Okay, so yeah, let's start from physical examination. I give you borderline, but maybe Dr. Mahmoud will give you.
Yes, Dr. Bassem, most important thing is I think
Yeah.
he must do ballotment of the kidney and also auscultate the kidney.
What do you think about why?
Yes,
What do I
patient
should
hypertensive, maybe renal cause, maybe renal vascular stenosis.
Actually, it could be related to her pregnancy, not a kidney issue. If he asked me more,
Mhm.
but he didn't correlate with the cause. He focused on something else. That's why he couldn't also
Yes.
analyze the hypertension, and he correlated to the family history of my father. But it could be related to the pregnancy. Okay,
You know, Dr.
hypertension at
Aminam, in my,
pregnancy. Yeah.
Dr. Aminam, in my exam, the examiner was beside me, told me, okay, what else you will examine? What else? What else? What else? I finished my examination already, and the examiner still tell me what else you would examine. Still, what else you would examine? I examined
Okay.
everything, Dr. Bassem,
Okay.
but he insisted to examine something. I don't know.
What is it?
I don't know.
Till now you
There-
don't know.
What was the
there
case,
is-
doctor? What was the case, doctor?
This case was bloody diarrhea. I examined the, no, yes, it is ulcerative colitis.
The digital rectal
I
examination. You offer
I do
digital rectal.
yes. First thing I tell here, I wanted to do digital rectal examination. I examine the abdomen. I also examine the heart and the back
Lymph nodes.
and lymph node. Examine lymph node. I examine. Dr. Bassem, me be the mouse. I didn't examine the mouse.
Maybe
الماوث
yes.
yes I
mouse.
agree إنه الماوث
Important
source.
for ulcer.
Yes,
Yes.
but I told the surrogate, your mother have any sores in the mouth? Told me no. So he may need to examine the mouth. I don't
No,
know
no.
really.
Even
إذا قلنا الماوث وحدة did you look for icterus لأنه بالعادة الألسرتيف colitis معها association BSC
Sclerosing cholangitis. Yes.
But
فالآي icterus pallor والماوث يعني هدول أعتقد من الجنرال examination وكمان مهمين للألسرتيف. وشغلة تانية البليدنج كان صار له قديش؟
this case, Dr. Hind was bleeding, was in vacation 2 weeks ago. And when I asked about any previous loose motion, he told me, yes, doctor, it is since 1 year.
بس بقصد إنه هل كان في possibility of postural hypotension because of the bleeding؟ لأنه
No, I told,
بهاللحظة حيطلب منك ال blood pressure setting standing.
I asked for blood pressure exactly, Dr. Hind. I asked
مو
for it.
مو ال blood pressure reading sitting and lying and standing.
Yes, I asked for here. Yes.
So يعني أعتقد معناتها مثل ما أنت قلت الماوث والآي لأنه أكثر 4 خطوات بننساهم
I
الديجيتال examination
examine the eye for pallor and jaundice and examine the mouse for central cyanosis, but I don't examine the mouse by my torch.
مجرد إنك أنت قلت له open your mouth فهي will automatically consider إنه you are looking for everything لأنه we cannot يعني أنت بالامتحان you're not speaking أنا عبالي ما فتحت الماوث
No, I open the mouse.
لا no need to open a torch يعني no need to open a torch you get me أنت بس على أساس فكرة التورش مو كل واحد لما يفوت على الإكزام بيكون معه إنه يفتح التورش ويشوف بس أهم شيء إنه you open the mouth
Yes,
you look
open
for
the
any
mouse.
source يعني it is I think covered
Yes, at the end of examination, the examiner told me, okay, what else you
what
want to
else
examine?
الماوث فتحته والعين شفتها والبوسترال طلبته
Yes,
وأمر
blood pressure وباك واللي هو lymphedema, everything, really everything.
Liver, you feel the liver? Maybe
Yes, all the abdomen was tender.
tremors.
Tremors I examined here already.
كان
Yes.
البيشنت شي على ستيرويد؟
No, لا دكتورة بس انت لا.
لأنه أحيانا بيدخلوا موضوع الستيرويد سايد إفكتس لو كان هو على ستيرويد.
Did you check
Back,
for
you can examine the back.
Yes, I examined the back.
The musculoskeletal system.
for
psoriasis.
انت عارف يا دكتور انا يعني هي الاكزامينر told me that no need. I want to examine the heart, no need. I want to examine the back, no need. The patient had back pain, so I want to examine the back pain. Told me no need. I want to examine the lower limb, no need. I want to examine the abdomen, no need.
بس غريبة بعد كل هاد سألك عن شي معين.
Yes, they told me what else? What
Might be because there is association between ulcerative colitis and psoriasis, maybe looking for the site of hairlines or something like that.
I didn't examine the hairline. Yeah, yes, I didn't examine the hairline.
Imagine محمود.
الهيدن areas والله it makes sense could be لأنه بالذات إنه أنت الباك بين كان عندك بوزيتيف. أحيانا الألسرتيف كولايتس الشغلة الوحيدة اللي بتخليها جزء من السيرو نيجاتيف سبونديلو أرثروباثي ولازم تدور على السورايسز ويو تشيك البندنج فورورد وباكورد والأشياء لما بيجيك باك بين، فربما فعلا هي صح.
Yes دكتور هند.
فما دام أعطاك الباك بين بوزيتيف دخلت بالسبونديلو. اوكي على الاقل فكرنا مع بعض.
This was suppose I say. Subhanallah, all group searching with Mahmoud what the examiner wants.
Yes. but really Dr. Basim was very kind. He told me, okay, you want to eat anything? Be sure.
لا بس يعني والله ترى بيوتر
Yes.
يعني لو متذكر مجرد ما
you
هو
will forget.
what else
Yes, mental block immediately on time. Mental block.
مع انه والله انا بحسهم اشرار، يعني لو قال لك in view of the back pain والله you could maybe remember it، لانه في اشياء كتير كلو يعني ما لا directly gonna remind you except if you have a clear concept يعني. بس anyway مو كل العالم بتحب تسوي.
Yes Dr. Hind, I want to examine. I told here I want to examine the back, no need.
لا بس قصد لو قال لك in view of the back pain كان خطر ببالك السورايسز. كان خطر ببالك لأنه عن جد كنت تذكرت السيرو نيجاتيف وفهمت علي، خلاك تفكر بدائرة شوي أصغر.
Yes.
على كل قدر الله وما شاء فعل، بس يا سيدي الله يجعله شو البونس.
Yes.
Okay, thank you, Dr. Mahmoud, for your experience. Now let's go to the mark again, Dr. Mahmoud. Physical examination, I think borderline for me.
Yes, Dr.
Although nothing in the patient in between attacks is free totally or she is free totally, but you have to examine in systematic way. This is my point, but you examine most of the points. Okay, you have to examine the mouth, open the mouth, the tongue out, the lip swelling, the eye. But it's no need for details eye examination or vision examination because she doesn't have any vision problem. The abdomen, yes, there is question which angioedema has abdominal pain. It's a hereditary type. Okay, so let's go to the finding, Dr. Mahmoud. How many? Because I think this case no finding, so he can get satisfactory if he examined most of the things.
Yes.
Okay, the clinical judgment.
Satisfactory, Dr. Basim, yes.
Clinical judgment, he gave the wrong diagnosis.
Yes. It is unsatisfactory. Sorry, Dr. Abena. Sorry, Dr. Abena. I remember.
افضل هنا unsatisfactory هنا على الاقل ما حغلط فيها ان شاء الله في الامتحان.
Yes, hopefully you will not forget it again. Okay, differential diagnosis, I think also it doesn't make sense to give me renal causes in facial angioedema or angioedema patient. It's a reaction rather than being swelling and edema or fluid overload. If you have
It's
Sorry?
the differential for buffness of the eyelid.
No, we always give differential for the diagnosis.
No,
Yeah.
differential for the symptom. Yes, you said to me before.
I said, but I
What-
notice they want about the diagnosis.
مو
So you
دائما
can.
مو دائما دكتور باسم عادي انت
Okay.
please wait the examiner question
Yeah.
يعني he will really tell you what is the differential diagnosis of angioedema in this patient or he will tell you what is the differential diagnosis of eyelid swelling يعني keep it for the examiner and
Yes,
if he asks you
I know, but sometimes most of the time they ask for the diagnosis.
لا
of
بس انت
anything.
اسأله انا برأيي نصيحة يعني if he ask vague
Yes, I
question what
supposed
is
to
your
do that.
differential
Yes.
diagnosis لا
Differential
تضيع
of what?
وقتك انت عندك 5 دقائق ask
Yes.
the examiner you want for the angioedema
Differential
or
for
for
the
the eyelid
yeah or yes
خلاص
exactly.
يعني without لأنك هتقعد تعدد وهو حيقلب يعني
Yeah, exactly.
وشه
And he will judge it as wrong in his paper.
yes you are right فخلص إذا عطى vague question guys يعني it's your right it's
Yes.
your exam and you are asking a
You
logical
can ask
question
him. Yes.
yes ask him is it for angioedema or eyelid
Yes.
swelling he will tell you
Yes. You're
خلاص
right, Dr. Shaima. Yes, I mentioned that before, but what I noticed in the exam, according to his mind, so better to ask him differential for the complaint or differential for diagnosis. Because if the complaint, it will be totally different. He will tell you at least show me your paper, what you wrote in your paper. Suppose if he's cooperative one, he will tell you show me what you wrote in your paper. And this one will be for the complaint, not for the diagnosis, because the diagnosis will be changed during the history taking and examination. So I don't know if they can judge on the paper, because in my exam I told him I wrote this in my paper, but he didn't look at all, and he judged on what I said. So better to ask him. I agree with Dr. Shema.
حتى موضوع إنه to take in account what you wrote on the paper أغلب examiner they don't take it in account بس be careful إنه some of them they take it بس إنه أغلب الأحيان لا nobody gonna read the paper which you have ف always better to ask the examiner in order not to waste your time وin order not to irritate him لأنه هو لو get irritated عدم لك الانفستيجيشن والمانجمنت فحتى لو كنت انت عم تعملي صح ف always ask don't answer any question without being sure what the examiner want it's your right and he will answer you clearly
I hope they will be cooperative, because we have already a lot of stress. He should be clear, or he can give me option or a choice.
بس انت بسؤالك خففت الستريس على نفسك
Yes, of
فهمت
course.
علي؟
I will be ready with my definition in the paper. It's ready. I wrote it
عليك
already.
نور من برا ولو قال لك
Yes.
الانجيوديما انت اوريدي مجهز الانجيوديما
Yes, exactly.
وحتاخذ نفس لانك فهمت وهو حسك يعني ممكن يعتبرها this is a good point from your side بدل ما انك to enumerate
Okay, so this is general advice. Anyone, the examiner ask him, what's your differential? Ask him what you mean, what you need from me, either complain or the diagnosis, because it will be totally different. In this case, yes, you can mention, as Dr. Abdulmain said, cardiac, renal, and even liver. But if not, it will be different totally during or through the differential of angioedema, if the case or the diagnosis is differential. This is my advice. And Dr. Hind also, I think, agree for this. Okay. So
Dr.
this,
Lee,
for
I want to ask which one of this angioedema is painful? Hereditary?
sorry,
Which one of angioedema is painful?
is painful.
Yes.
Any edema will be painful. It's not related to the type. Yeah. Imagine swelling of your eyelid. It will be tense, right? You got it, Dr. Shaima?
Okay, doctor. Oh, thank you.
I think دكتور باسم يعني قصدها tummy pain which angioedema
okay.
with
Tummy
tummy
pain.
pain
I said hereditary
yes
angioedema.
but not
The others always in the face, not generalized, or not always. I mean mostly. Okay. Okay. Back to the differential and the score. You said borderline in the differential, and also borderline in the judgment, and the last concern and welfare. Do you think he will have the mark in both, Dr. Mahmoud?
As you like, Dr. Basim. As you
Okay,
like.
خلاص. Okay, most of the examiner, by
Okay.
the way, giving full mark in the concern and will finish
Yes,
unless
yes, I think.
you harm the patient, either by feeling or by something like rough in the examination. Even wallahi, some comments to my colleagues, they mentioned the doctor was rough in the examination and they didn't minus in the welfare. They minus them in the physical examination. Imagine. So most of the welfare and concern you got full mark. Okay, so total you have 2 or 3 borderline: physical examination, differential, and clinical judgment, doctor. Yeah, remaining clinical communication. I think also borderline you missed some of the points you have to ask about, although you ask about most of the system. But still, the stress is important here. You ask about the mood, but you didn't ask me about the stress. You didn't ask about food allergy, which is important. You ask about only drug allergy, which is not necessary to be only for drug. Allergy even sometimes even with the pollens or exposure, okay? Like in asthma.
Actually, I
But,
tried very hard, Dr. Bat. I tried very hard to
Doctor,
finish my history within
yes,
8 minutes.
I really, what you did is great, but sometimes when you do practice, when in a case or in a diagnosis, you will never forget it again. So
Mhm.
now you have the 5 types. Whenever you have this case in the exam, you will go through all types, and one by one you will either roll out or roll in.
Yes, but my point that I
Uh-huh.
tried very hard to finish my history within 8 minutes
Yeah, you
because
finish it quickly, yes.
because the last time my exam I finished like in 9 minutes, and I found myself just staring for the patient and just 2 minutes and 2 minutes remaining. So I lost almost all of the grade for the examination and findings.
Yeah, that's why I always said whenever you catch the case, you can jump to the examination, and during examination you can ask some question missed or remains, like social or occupational. But try to finish the system review and past medical history as soon as possible, along with analysis of the complaint, and go to the patient to examine him. At least you will get the 8 marks of examination and identify finding. Clinical communication, anyway, it's 4 marks. And you can reach, most of the case, you can reach from the system review and the complaint analysis and some differential you put in your paper. And I prefer to do the differential analysis. So in this patient, for example, if you suspect angioedema, go through the questions of angioedema for each reason or for each diagnosis. One question or according to your knowledge, if you have 2 questions for some type, or if you can confirm the type by 2 questions, it's more than enough. But roll out the others and system review very quick and examine the patient. While examining the patient, you can finish the social and the occupational. If you finish the examination and you have time to sit, you can complete the others before the concern. Okay? This is my advice, because 8 marks will be a matter for you.
Okay, Basam, I have one comment.
Yes, go ahead.
Regarding Dr. Abdul Maneem, in my opinion, I'm very much impressed the way he has confidence. He proceeded the case in a very, very professional manner. Only there was something missing, but he finished the history on time and he was full of confidence. And inshallah, he will never forget this scenario in future. And one my more advice is, if you are thinking regarding the eye puffiness, you are thinking about cardiac problem, renal problem. So immediately you will ask one question: weight gain. If weight gain, then you can think of cardiac problem, renal problem, or in case of ladies, you can think about peripartum cardiomyopathy. If there is no weight gain, weight is normal, most probably you will not go this systemic review. You will consider about the angioedema. This is my advice.
Thank
Yeah,
you so much.
thank you, Dr. Azhar. Please post the case, Dr. Abdul Malik. I will try to finish the comments quickly.
already in the chat box, Dr. Basim.
Okay. I think, yes, most of them mention the types, the danazole as a prophylactic, also tranexamic acid in female, danazole in male, and acquired. It can come again, need only surrogate. Yeah, it comes a lot of candidates and a lot of centers. It's a very easy scenario, and you can also need surrogate, no need for patient because it comes and goes. Acute and chronic treatment for hereditary type. So an acute C1 inhibitor concentrate. If not available, you can think about FFP. This is for the acute attack. Of course, after ABCD approach, you have to secure the airway, be sure about the circulation, the cannulas, and all this stuff. For the chronic type, according to the gender, if female, you can give her tranexamic acid, and in male, you can give him danazole. This is simply, okay, plus education counseling. Okay, but don't mention EpiPen. EpiPen only for allergic type and the idiopathic type. For the drug induced, as Dr. Aminam said, stop the offending drug. Minimal change, nephrotic syndrome, also differential. Of course, if we mention the eye puffiness only, lab test in acute attack for both hereditary type and allergic. What about OCP? Yes. OCP, I guess it's a risk for, no, I am not sure. Any relation you mean OCP? Trigger? I don't think it's trigger. If someone has the information, he can share it. OCP,
No role in this scenario.
yes. Okay. PR, I think he's talking about digital rectal examination for Dr. Mahmoud case. So, see, Dr. Mahmoud, the group now looking for your lost.
Yes, doctor. No.
Validate.
I did. First thing, Dr. Basim, I asked the examiner for digital rectal examination. First thing, really.
Dr. Mahmood, when your result?
Yes, Dr. Basim. Yes, Dr. Asar.
Yes, when your result will come? Inshallah, it will be good. Inshallah.
Inshallah.
I'm
Thank you,
very
Dr.
hopeful.
Asar.
I'm very
بس
hopeful.
دكتور محمود لا تنسى تطلب الفيدباك الله يسعدك.
شور دكتور هند.
وبعدين على شغلة تانية، أنت حكيت على الكيسات بسيشن، يعني أنا
Yes.
فاتني سيشن حكيت عنهم ما هيك؟ وحسيت
Yes.
ببقى إذا فضيت دكتور باسم بعت لي بس كان أي تاريخ أنا برجع بالريكوردز بسمعه.
Okay.
Okay.
The same day I told you he thank you specifically, Dr. Hind.
كان
But
طيب.
I think it is not recorded, Dr. Basim. I
Ah,
think.
yes. We started without record, yes.
Yes.
We can repeat it, Dr. Hind, for you, no problem.
If you want, Dr. Hind, now.
After the second case, we can
على
repeat.
راحتك، يعني إذا
Okay,
الموضوع
after.
إذا الموضوع هيك يعني ممكن احتوائه بفترة بسيطة بكون شاكرة لك.
Okay, after the second scenario, we can have a
Okay.
discussion about
خلاص
Dr.
أوكي
Mahmoud.
يسلموا
Okay.
كتير.
Most welcome. Not painful, numb only. Yes, numb only. Yes, I agree. It's not painful because of the swelling. When you finish early, summarize to the patient. If you finish early, most of the time you will be examining or taking history. Unless the diagnosis is very clear and you finish everything quickly. But most of the time, you will finish on time. Okay, but if you have time, yes, good point to summarize and to ask him what I miss. If you want to add anything, please. Okay, Mr. Edward, 35 years, male, present with hematuria. Okay, so it's again related to the kidney. Okay, let's start, Dr. Abdul Minan.
يلا.
Okay. Hello there, I'm Dr. Mukhtar, the doctor in the clinic today. You must be Mr. Edward.
Yes.
You are 35 years.
Yes, doctor.
I'm here to take history from you and to examine you. Is that okay for you?
Yes, sure, doctor.
Can you tell me what you have suffered through?
Yes, doctor. For 1 week, I have noted that my water work is changed to red, And recently, I'm afraid that to be like a blood. I went to my doctor and he referred me to you.
I'm so sorry to hear about that. Is it the first time ever?
Yes, doctor.
And you said 1 week back.
Yes,
So it started all of a sudden.
yes.
Okay. Do you have any trauma to your back
No,
or to your private area?
no.
Okay. And you notice this blood increasing?
Yeah, I think that.
Increasing.
Yes.
Okay. Do you notice the blood coming at the beginning of your beat? Sorry for this question, or at the middle, or throughout, or at the end?
Throughout my waterwork.
Throughout. And is
Mm-hmm.
it fresh blood or dark?
I'm not sure, doctor.
Okay. How about the amount? Is it decreased or increased or the same?
I think for the last couple of days, it is reduced compared from the previous days.
Okay. And did you notice any stone coming with your water work?
No,
Any history of stone?
no,
Okay. Any pain at your back or at your tummy?
no,
Okay. Uh, Apart from this, you have any history of infection recently?
no, doctor.
And do you feel some burning while being?
No.
Any difficulty to pass?
Sorry?
هذا المشترك لازم.
Any difficulty to pass the water work?
No, no,
Okay. And any pus coming? Sorry for this question.
no.
Nothing.
Mm-hmm.
Okay. Are you diagnosed with any long-standing disease, Mr. Edward?
No, doctor.
Any surgery before?
No,
Any allergy?
no at all.
Any herbal remedies?
No,
Over-counter medication?
no,
Any blood thinner medication you took recently or before?
no. I have been always healthy person.
Okay, good. Apart from this, you have any change of your weight?
No.
How is your appetite?
It's good. Nothing changed.
Any high body temperature?
No,
Any lumps or bumps?
no,
Night sweats?
no.
Okay, I will ask you some question, if you don't mind. If you have any headache,
Headache, no.
any change of your vision?
Yes, doctor. My problem with this vision started like 1 week ago
Okay,
when I have noted that even my I have some sort of blurring of vision.
okay.
Mm-hmm.
And both eyes?
Yes.
Any change of night vision?
No.
You feel double? Seeing double, I mean?
No.
Only blurry.
Yes.
Any redness in your eyes?
No.
Any swelling around your eyes?
Yes, doctor.
You feel swelling in both eyes or one eye?
Both eyes.
Both eyes, okay. Any difficult swallowing?
No.
Any nose, a change of your nose shape?
No.
Any crust in your nose?
No.
Any coughing blood?
No.
Any difficult swallowing?
No.
Any intolerance to any weather?
No.
Any swelling in your hands or legs?
No.
Okay. Any sore throat?
No.
Any chest pain?
No.
Any short of breath?
No.
Any noisy breathing?
No.
Okay. Any tummy pain?
Tummy pain? No.
Any change of your bowel habit?
No.
Any feeling thirsty?
No.
Okay. Any skin rash?
No, doctor.
Joint pain,
No,
back pain,
no,
any muscle pain,
no,
any pins and needles.
no,
Anyone told you are paler than before?
no,
Any yellow in your eyes?
no.
Okay. Any family history of same condition?
Actually, doctor, my brother have this blood in his water work and thing start at the same age of my age now.
Okay. And how is he now?
He's good.
And he have any diagnosis?
No,
Okay. Any other family history of note?
no,
Cancer,
no,
kidney problem.
no,
Okay. Any travel recently?
no, doctor.
Okay. Um, sorry for this question. You have partner?
Yes,
Any casual relationships?
no,
Okay. Apart from this, you are using any recreational drugs? Sorry for this question.
no, doctor
Sh-
at all.
sharing needles?
No,
Okay. Do you smoke?
yes,
How many for how long?
10, 14 years.
And do you drink alcohol?
No,
Okay. Smoking is harmful for your condition, and I advise you to stop smoking. Is that okay for you?
okay.
What's your job?
I'm bank accountant.
And how the impact of this on your job?
It's affect a lot, doctor.
Okay, I'm so sorry for that. We will try to help you. Do you drive, Mr. Edward?
Yes,
And I think it's also affecting you driving by this vision problem, right?
yeah, I think that.
Okay. I will examine you now, Mr. Edward. Is that okay?
Okay.
So I will start from the hand. Any
They are looking for
vital chart.
pulse rate 89, blood pressure 150 over 95.
Are you diagnosed before with high blood pressure?
No, doctor.
Okay. Now I will the character of the pulse. I will examine the character of the pulse. Any
Good volume.
good volume and synchronous, regular.
Yes,
The pulse volume,
normal.
normal. So it's not collapsed pulse. Any signs
No,
of dehydration in the hand, the skin
no,
turgor,
no,
any leukonychia, colonychia, clubbing.
no,
In the palm, any change in the palm, pallor.
no,
Okay. Now I will ask for posture hypotension, blood pressure sitting and standing.
negative.
Do you feel dizzy while standing, Mr. Edward, from sitting?
No,
Okay, I will examine the face now. Going to the eye, any pallor or jaundice? Can you look up and look down?
tumbler and some joint. Some. Just let me 1 second. I will share the. طيب
Okay,
أنا هرسل لك
okay,
الصورة
okay,
للآي. Okay, لحظة بس. You can share it.
okay. Apart from this, you have any? I will examine the face. Any telangiectasia?
No telangiectasia. The image of his eyes on the WhatsApp group.
Okay, so no telangiectasia.
No.
Okay, I will examine now the eye for retinal red reflex. Sorry,
Positive.
positive or lost.
Positive.
Okay. Uh, so the acuity is impaired.
The acuity is impaired.
Yes, he cannot see. So I cannot do the fields.
No.
Okay.
No need.
The pupil reflexes.
Sorry.
Pupil reflex to the light.
To the light reactive.
reactive.
Mhm.
And the H shape, any change, any double vision or pain?
No need.
Okay. Did you notice the vision affected more to the up or down?
I didn't notice, doctor.
Okay. Your brother also have the same problem in his eyes?
Yes, doctor.
Okay. And he has any history of blood clot or you?
No. No.
No history of blood clot.
Mhm.
Okay. Any redness around sclera, I
No.
mean? Nothing.
No.
And you deny any telangiectasia in the face? I will open his mouth also to examine for any bleeding or crust. The mouth and nose.
No need.
No need. Okay. Quick examination to the neck. Any rash?
No.
Nothing. And
Mhm.
I will examine the heart for any murmur.
No murmur.
No murmur. Okay. Now I examine the chest. Any bibasal crackles?
No need.
Any crackles or added sound?
No.
Nothing. The abdominal examination. Superficial palpation. Anything I can feel or any tenderness?
No.
Still no telangiectasia.
No telangiectasia at all.
Okay. Deep
You
palpation.
missed one examination and one question in the history. You would
Okay.
cover everything except this diagnostic question in the history and one test in the examination.
Okay. Uh, Let me do deep palpation for liver and spleen.
No need.
No need. And the palatable kidneys. Any
No
palatable
need.
kidney. I will auscultate for renal bruit.
No need.
Okay. Now I will examine the legs for any swelling.
No need.
Okay. I will ask or offer to do examination of inguinal lymphadenopathy and
No need. No need.
genital examination.
No.
Okay. Uh, so, Mr. Edward, I will summarize, and if you want to add something, you can add. You have suffered blood for the first time. It happened with you and your brother, and the blood throughout the waterwork. Apart from this, you denied any history of change of your weight, appetite. You want to add anything else?
Actually, doctor, yeah, I have one more problem with my hearing.
Okay.
2 minutes.
Since when this problem?
2 minutes remaining.
Okay.
Here.
What I know, what's your concern? May I know what's your concern?
What I have, doctor, is it something serious? And I'm planning to start family. How is this? What is this disease going to my kids or no?
Yes, actually, your concern is valid. You might have a condition which might be familiar, and to be having safe babies, we have to do screening for this before having pregnancy or planned pregnancy with your wife. You have other concern?
What I have, doctor?
Yeah, you might have a condition called Alport syndrome. It's a condition runs in family, and you have possibility to run this disease to your kids. You have other concern?
Is it treatable? And how you are
Actually,
going to help me, doctor?
yes, we will admit you under a group of specialists. We will refer you to a group of specialists and doctors. They are professional in this, including the kidney doctor and also the hearing doctor. They might help you in the symptoms and they will help you in most of these symptoms of the disease. Uh, in the future, if you need any social support, also you can add the social and occupational therapist to the team regarding the hearing might be affected. You have other
I'm
concern?
going. Yes, my last concern. I'm going to end with bound to this dialysis machine.
I appreciate your concern. We will refer this question to the kidney doctor. He will sit with you to answer all these concerns in details.
Okay, thank you, Doctor.
However, you might have the possibility of this. Okay, you have other concern?
No, thank you.
Okay.
Present your case.
Yeah, Mr. Edward, 35 years, came with a complaint of hematuria. I started all of a sudden since 1 week. It happens with no preceding precipitating factor or no preceding infection. Vision deny any other complaint apart from vision affection, blurring of vision, and also he add at the end hearing affection. This problem in with him and with his brother. He's a smoker, and we give him advice regarding the smoker. Apart from this,
So
I
was,
call yes,
what did you find in his eyes? On eye examination.
yeah, it's cataract.
It's not cataract.
It's
This
lens.
this image, the second image
Yeah,
from
okay.
laterally, this lentoconus,
Yeah,
which is
the lens is
protrusion.
downward.
No,
Downward or
protrusion
so?
of the lens.
Okay.
Okay. So what is the type of hearing problem? Or
Sensory neural hearing loss.
how did you know?
Uh, it's a common association with Alports. But I didn't,
But you
however,
didn't.
I didn't examine. Yes, supposed to examine. Yes.
Yes, yes.
But most of the
So,
hearing familiar condition will be in sensorineural.
yes. What's your differential diagnosis?
Yeah, Alport syndrome on the top. I put also homocystinuria. I put also the GPA. However, no symptoms of renal affection, sorry, of respiratory affection or upper respiratory tract affection.
What else?
Eosinophilic grammatosis polyangiitis and
Regarding the hematuria?
glomerulonephritis.
Okay.
However, no history of infection or drug intake to be precipitated.
Regarding this inherited hearing loss,
Yes.
what
Uh,
could be the differential for this
yeah,
inherited
Alport syndrome,
Mm-hmm.
Usher, and
Yes.
Refsum. But it will be associated with others condition, not this one.
Okay, how you are going to investigate your patient?
Yes, baseline basic investigation and specific investigation and bedside investigation. Specific investigation in the form of renal function test, urine analysis, and urine culture as well. Also specific for the hearing, you could do hearing tests.
What else?
Bedside test, it will be the urine dipstick.
How you can confirm your diagnosis?
Genetic, of course, screening.
What else?
Other renal biopsy.
What do you expect to find in renal biopsy?
It will be the finding a characteristic with Albert syndrome,
Which is
which
okay.
which is the characteristic finding of Albert in Albert syndrome.
Okay, fair enough. Fair enough. So, what is the mode of inheritance of Albert?
Yes, it's autosomal dominant.
What is the most common mode of inheritance of Albert?
Yeah, I guess X-linked dominant,
Yes,
not
that's it.
not autosomal. Yes, I remember
Yeah.
now. Yes.
Yeah, X-linked is dominant. So, how you are going to treat him?
Treatment under multidisciplinary team approach after counseling, education about the condition and the complication and the association, advice about smoking, good hydration, plenty of water, diet advice, and for the eye and the vision, advice about stop driving and informed DVLA. Hearing also should be counseled with the occupational therapist, adding to him some aids, hearing aids, and for the eye also, if they can help him with the occupational therapist. Apart from this, the nephrologist will be included, the ENT doctor, the ophthalmologist, social worker, and physiotherapist specialized nurse. For the for pharmacological therapy, no specific medication will be added, only symptomatic and supportive treatment, plus genetic counseling for his family in the future.
Okay, what is definitive treatment?
Definite treatment, renal transplant as in the list.
Okay, do you expect if this patient underwent renal transplantation, do you expect the recurrence of
Yes, it's
antibiotic?
possibility to be having high rate of recurrence, but
High rate of recurrence?
yes, high rate of recurrence
High rate of recurrence or high rate of rejection?
of rejection because of the recurrence of the disease.
No, it's
Of
completely
antibodies,
different.
yeah, recurrence antibodies against the kidneys, the new kidney. You mean?
Yeah, there is high risk of rejection. However, the recurrence is very rare.
Okay.
Okay, thank you, doctor. Now you can go to the next station.
Thank you, Dr. Abdul.
Actually, this Basim, this case came to in Kenya Center. However, the patient
No,
was
oh my
had,
God.
but the patient have hearing aids. It's clearly
Okay.
one. Yeah,
Spot diagnosis. Yes.
yeah. but I cover this soon.
Dr. Basu,
The-
you asked all the question. I was thinking how you forget about this hearing, because
oh my God. Yes.
hearing, it was correlated with
Yes.
Alport
Yes.
syndrome.
Yes. Yes.
I
You're right.
want to give you here some hint, but lekin Dr.
Yes.
Abdul
Yes. You're
Manin.
right. You're right. See, one question only for the case.
Yes.
Yes. Dr. Abdul Manin, can you, I do not know about this eye picture. The lens is
This
downward,
lenticonus,
upward.
this is a pathognomic feature of Albert. There is separation of the lens. Can be this image from lateral view, so you can clearly found that the lens can be protruded from the eye, from the iris, and can even by naked eye, no need for even for fundoscopy. Lenticonus, you can just Google it, or I can send more photos about this because it's pathognomic for Albert syndrome.
Because I'm always confused about Marfan, homocystinuria, whether it is upward. In Marfan, there is upward dislocation of
Upward
the lens, and
dislocation.
homocysteine downward. How I remember is Marfan mean F mean fan. Fan is always upward. So Marfan, it is always upward. Homocysteine, it is downward. But I never diagnose on the picture. I could not
Yes,
diagnose.
sorry. Yeah.
It's difficult.
Even I think the hint was the hearing aids, very clear in the exam.
Yes. But Dr.
Otherwise,
Basu,
you covered.
all the question, I was
Yes.
thinking why he's not asking hearing. Why he's not asking
Yeah.
hearing.
See, one point only can miss the case.
Yes.
Mhm.
Okay, but if hearing will be noticed, I think it will be spot diagnosis and pathognomonic. This is the first thing. How
Mhm.
if you didn't notice the hearing? Will he add to you a clue when you ask such question, Dr. Abminim, about your experience? Do you think the
I'm not sure.
surrogates?
I'm not sure.
Yeah,
I think the family history would be the clue.
I suspect homocystinuria, to be honest, because of family
Mm.
history also, but never Albert I put in my differential.
Homocystinuria normally come with by hematuria.
Because of stones
Yeah,
formation,
but
right?
this is a clear hematuria throughout the blood.
Because
So
of
it's frank.
antibodies, yes.
Yeah, this frank hematuria.
You know, yeah,
Thromboembolic history in
yes.
homocysteine.
I ask about the clots, but
Yes, you
subhanallah,
ask. That's why I'm saying you ask each and everything.
Literally everything.
everything,
You've
yeah.
covered everything.
But subhanallah, every day and every practice you learn a case and a diagnosis, really.
Yes.
And I am wondering, it comes in exam, Alport syndrome. And they brought a patient with Alport syndrome. Oh my God.
Where they got the
So,
patient with Albert syndrome, Dr. Basim? In
Dr. Bass,
Kenya.
Kenya, I don't know, Kenya.
they bring pseudo hypoparathyroidism. So I think this is the most rare disease ever.
Albright syndrome.
Mark-Albright, yes.
But
So you can expect find anything in the exam.
yes, sure. By the way, pseudo hypoparathyroidism, nothing in the labs, right? Only the finger, short
Yes.
fourth finger only.
Short stature and the structural changes in the fourth and fifth.
But the all bone profile normal, right?
Bone profile, yes. But in case you added the parathyroid hormone, there is no in normal hypoparathyroidism you will find increase cyclic AMP, for example, and phosphorus. However, in pseudo hypoparathyroidism, neither cyclic AMP or phosphorus will be raised. Urinary test. So this is the main differentiate between pseudo hypoparathyroidism and hypothyroidism.
Okay.
Dr. Basa, a beta
Yes.
lipoproteinemia also appeared in the case.
What?
A beta lipoproteinemia.
Yes, as a retinitis pigmentosa association. Yes. Yeah, but
I do not know, but the patient will, in this case, the patient will have ataxia also.
ataxia and diarrhea, malabsorptive diarrhea.
Yes.
Yeah,
Very,
I guess
very rare.
retinitis pigmentosa as a
Yes,
case, yeah, it's. I hope it's clear. I mean, with the differential. So either syndromic or non-syndromic. You have to ask and screen other syndrome. Alport, I know about Alport, but I didn't expect it will come in exam. We are putting them in the differential, in the renal failure. But as hematuria case,
Albert syndrome usually it comes also with retinitis pigmentosa. Yes.
No, by the way, there is no retinitis pigmentosa in Alport.
no, it wasn't in the differential.
There is no
Alport.
retinitis pigmentosa.
ثواني لا تتزاعلوا على هالنقطة، لأنه تزاعلوا عليها الأوفثالمولوجي والنفرولوجي. في ناس بتقلك في ريتينايتس بيجمنتوزا لأنه إذا بتطلع على الألبورت جيناتيك ميوتيشن عندك كولاجين أنواع لا تعد ولا تحصى، فبعض منا أفكت الكولاجين بيزمنت بقلب الآي. فمشان هيك يلي في ناس حلفت يمين أنا عايش طول عمري بحياتي ما شفت البورت وجايني بريتينايتس، وناس نفرولوجي قال لا نحن بندرس بالكتب وبناخد بورد اكزام وطول عمره بالريتينايتس بيجمنتوزا في البورت. فهي خناقه كتير كبيره ما لكم مصلحه تفوتوا فيها ابدا.
Yes, but I
because
remember,
I did a lot of research about this point and I didn't find
agree معك. انت عادي بالسورسز العاديه وقت منفوت على جوجل ترى ما بنلاقي، لكن فعلا بالبورد اكزام وبالسبيشاليزيشن اكزام بالنفرو واحد من المانيفستيشن للألبرت بالذات انه هن بيدرسوا كل انواع الكولاجين ميوتيشن، لازم يكونوا بيعرفوها لانه it's very important genetic disease بالنفرو بالذات النفروبيدز. فيعني نحترم رأيهم واكيد هن عندهم يعني السورسز تبعهم اللي مو موجوده عندنا على جوجل، ف they really said انه it can be. لكن خلينا نقول انه الألبرت as a case of hematuria is more common than Albert as a case of retinitis pigmentosa. نتفق على هالمعلومة لأنه هي معلومة سليمة، إنه أنا إمتى I should suspect ألبورت بحالة هيماتوريا ولا بحالة فيجن؟ لا، بحالة هيماتوريا خليها ببالك أكثر، أو hearing problem. تمام، لأنه في كيسات hearing problem بتجي. تمام، فهيرينج وهيماتوريا الألبورت على راسي. retinitis pigmentosa as Dr. Bassem said, keep it as a differential but it's less likely to be as a case.
Yes.
Okay.
But it's one of the differential. You have to put it. Yes, Dr. Azhar.
My question is, if as the end you did very well, you summarize the case and you said, do you want to anything or this is enough? And now it depends on the surrogate. If he will not add you anything,
he will never tell you anything. He will never.
No. Some surrogates are kind.
Really?
Yes.
I think
hopefully.
The problem إنه لما السيروجيت والexaminer they are kind, you have two possibilities.
Yes.
Either the examiner will not count it as a prompting, and if you needed one prompting and your performance was perfect, so it will not be counted in the feedback. A second scenario, if he's a difficult examiner, even single prompting or starting from the second prompt,
minus,
he will consider this in your feedback, and it will be written clearly the candidate needed prompting or needed prompting multiple times. تمام. فيعني sometimes be happy
Mhm.
sometimes يعني بس don't wait a prompt.
Yeah.
Don't wait a
Yes.
prompt at least يعني neither from the candidate nor from the examiner because you might pay the cost of this prompting and you might not يعني إن شاء الله if your performance is good. But prompting is a negative point usually.
Mhm. Okay, thank you, Dr. Hind. But let's have the score from Dr. Abdulmalam and Dr. Mahmoud, of course. No, Dr. Mahmoud, no.
You know, Dr. Basim,
Yeah,
over
no,
satisfactory, Dr. Basim.
no.
No problem.
That's why I said no. I will get over satisfactory without, even if I said hello, I am, and I finished the examination.
Oh, very good, Dr.
without-
Basim. ما شاء الله. Very good.
الله عليك يا ست.
هاي محمود بيشتغل بالسمعة. اللي سمعته لا غبار عليها بيمشي.
Okay.
Yes, Dr. Basim, over satisfactory. Sorry, Dr. Abdulmalam, over satisfactory, Dr. Basim. Please.
Dr. Abdul Manin, in the biopsy, what will be the findings as you asked from Dr. Basim?
Yeah, basement membrane antibodies, I think, right?
Yes, splitting of the
Maybe
basement, glomerular basement membrane. And here, the light microscopy is not that important. The gold standard electronic microscopy is
This is the
showing,
thin. This is the thin membrane, right? This is the
yes,
thin.
thinning
From part.
splitting of the glomerular membrane. Yes,
Yes, I remember now. From
basement
bar two.
membrane. Yeah.
From bar two. Yes.
but
Okay,
you
and you said
but
you
you
said
forget.
no rejection. It's antibodies.
The problem in post-transplantation in rejection is highly, the rate of rejection is very high. However, the recurrence is very low or rare.
Okay, so
The
rejection
highest
itself.
recurrence in focus segmental glomerulosclerosis and
Yes.
IgA nephropathy and
Yes, focal segmental glomerulosclerosis.
mesenteric capillary.
mesenteric capillary. Yes.
capillary.
Yes.
بس البوينت هون دكتور باسم الريجكشن is not due to the recurrence of the disease. تمام.
Antibodies. Yes.
الريجكشن is due to the انك انت لما بيكون في عندك شخص ما عنده كدني او عنده اسفه لا عنده انتي بودي against البيزمنت ممبرين.
Okay,
تمام.
so it
هدول
will
لانه
attack
ما
again the
عندهم
new
بيزمنت
kidney.
ممبرين فلما بتعطيهم كدني سليمه فيها بيزمنت ممبرين
It
they
will attack it
develop
again.
GPM. They develop good posture picture.
Okay.
تمام.
It
It is
attack
not
the membrane
recurrence
again.
of the Albert. The kidney is fine and this patient has no Albert anymore. But unfortunately, since you gave him a healthy kidney and he's not used to this type of antigen, his body will recognize the new basement membrane of the new kidney as a foreign body. He will develop a new condition called glomerular basement membrane autoantibody. تمام. فما حنسميه هون good posture بس حنسميه GPM auto antibody as a cause of rejection. فمشان هيك الريكرنس هي ما كانت الكلمة الصائبة. rejection هي
Yes,
الكلمة الصح.
rejection by another way. Yes, okay.
عليك.
Okay, thank you, Dr. Hint, for clarification.
And I think, Dr. Abdulmalam, treatment is ACE inhibitor, yes?
Yes, exactly.
Not.
The best.
But Dr. Basim forget driving about the driving, Dr.
No,
Basim.
no,
He
I
didn't
mentioned.
stop the driving, right?
I
No,
said.
no, Dr.
He
Basim.
stopped the driving.
I said.
I wrote it in your feedback, Dr. Basim. The candidate did not stop the patient from driving.
You know,
No, wait. I said.
He said that you have vision problem, so that's
Yes.
why I advise you please stop the driving and inform
Really?
DVLA. I remembered his words.
Okay, in the examiner question or for in the page in the history?
In the history.
In the history, I said, "Do you drive and what's your job?" I ask.
Okay. So my bad.
No problem. But in general, I think homocystinuria as a differential will be accepted because of family history or what, Dr. Hind or Dr. Abdulmalam?
ما سمعت السؤال شو كان؟
Yes, the differential as the homocystinuria. What's the differential in this page? Good posture syndrome?
لا الديفرنشيشن thin basement membrane لأنه فاميليال ومعه هيماتوريا بس there is no hearing. وفي تاني واحد اسمه loin pain hematuria syndrome هذا كمان فاميليال ومعه هيماتوريا و it's a very benign condition يعني patient like الألبرت بس مشكلته الألبرت إنه he will have eye problem, hearing problem. But these people, they can really survive يعني if it is not that severe mutation. always whenever there is familial hematuria, تمام, and you have normal size kidney, so you can give the loin pain hematuria syndrome and the thin membrane hematuria syndrome as a differential for Albert. But طبعا there is no hearing loss, there is no other organ involvement. good posture is a good one لأنه عندك
Yes.
hematuria, but المشكلة good posture is not a familial disease. تمام.
Acquired.
يعني it's not a familial. والألبرت have no pulmonary presentation. it will be only a differential, good differential for rapidly progressive hematuria. Even if the hematuria is over long time, because this is a familial disease, this is another negative point which will make good posture not a good differential يعني. I prefer إنك to give those familial options. تمام؟ حتى
Okay.
KD إنه it can be لأنه it's familial,
Yes.
it can lead to hematuria, and in early stages you might not have ballotment. It's
Yes,
also a good
APKD one of the
difference.
differential. Yes.
Yes, you're right.
يعني since it is a familial hematuria, I didn't find could be early, especially if your patient is young.
Yes.
So you have to give something familial at the end. تمام? Because there is a family history يعني. And it runs
Okay.
family. So I prefer those يعني. But if you
Okay.
come up with anything after Albert, بس أهم شيء نلقط الألبرت. للأسف من زمان كان في examiner they count your differential correct if you kept the correct differential as a second or third. Recently ما بعرف ليش صايرين examiner too much mean to extend إنه they are waiting for a specific diagnosis and it should be on the top.
Yes,
they are
exactly.
very sensitive. لما مثلا أنا بقول لك syncope, طب أنا متعلمة إنه any case of syncope I should exclude cardiac syncope. good practice مني إني أنا لما بتسألني what is the cause of this syncope, أنا بعرف إنه this syncope is a postural, بس I will tell you cardiac syncope postural. مشان هيك ننتبه, we have to be very careful. Don't say cardiac syncope as a top differential just because you need to exclude cardiac syncope in every case. No, you should say after excluding cardiac syncope,
Yes.
my top differential is postural hypotension. لأنه really we have a sick examiner, طيب, who will not
Yes.
understand this point. يعني ما حيحترم إنه أنت you are in stress يعني بس you
No,
mean
no,
it
no,
والله
they
يعني
are not.
when I will put cardiac syncope top, this is what I mean. I shouldn't say والله after exclusion of. But still, والدليل على this approach that it is the best approach الكيس الشهيرة تبع الجيرد which they are waiting you to exclude the ischemic heart disease. And we should say that despite that the pain is atypical and it's completely consistent with GERD, but in view of the risk factor, I would like to exclude the ischemic heart disease. From now on, if there is a critical differential in your mind, like seizure, cardiac, hypoglycemia,
Put it in the top.
no, don't put it on the top. Mention this, that after excluding this
Ah,
critical,
okay.
my top differential is after excluding of those collection of critical diagnoses. They are not my top differential, but they are critical and they need to be excluded. My top differential is postural hypotension. My top differential is vasovagal, which is the benign one. My top differential is GERD. تمام. at this point you are professional, you excluded the critical, you maintained your top differential as a top differential, so you escape from that sick examiner. تمام.
Yes.
Even if we learn something that it's a critical and it is a fixed differential مثل TIA in case of migraine, hemiplegic migraine, قلبي حيموت بدي أقول TIA. mention TIA but say after exclusion of TIA and stroke, my top differential is migraine, hemiplegic migraine. تمام. it will be counted as a differential, it will be counted that you are safe doctor, it will be counted correct differential diagnosis skill for you. طلعت تطلق عصافير بحجر واحد. تمام.
Yes.
I hope it's clear and be
Yeah, yes,
careful.
clear.
من زمان it was not an issue. عادي كان نشوف.
Yeah.
Recently he is writing the candidate kept hypoglycemia as a third differential. وهي start وحرام بتشوف انت الديفرنشال they are all differential يعني كاتب cardiac syncope, postural hypotension وhypoglycemia ويعني it's not bad arrangement والله borderline والexaminer الثاني unsatisfactory. please be careful, too much be careful. تمام.
Okay. Yes. Okay, thank you, Dr. Hind. Thank you, Dr. Abdulman, for the case and practice. I will read the comment quickly. Someone asked about the retinitis pigmentosa differential. Good question. And I think Dr. Abe, answer the Usher syndrome, beta lipoproteinemia, Kearns-Sayre, and also sometimes you can add Alport. And the last one, what's Lawrence Montbedel syndrome.
And
This is
Usher syndrome.
Usher written already, not written.
Ah.
Usher, Usher, Rifsum, beta lipoproteinemia, Kearns-Sayre. Of course, everyone has a specific question. So for the Usher, hearing problem. For beta lipoproteinemia, ataxia with diarrhea. For Kearns-Sayre, cardiomyopathy and bradycardia. And Rifsum, we will have peripheral neuropathy and ataxia.
For
And
Refsum also the hearing problem.
yes, I will share it to the group.
Usher, Refsum, and Alport, these three, they are associated with the hearing problem.
Yes, but you will add something with, like for Alport, the kidney plus hearing and eye. Usher only hearing. Rifsum, you will add peripheral neuropathy to the retinitis pigmentosa and the hearing problem. Kearns-Sayre will be for the heart. Beta lipoproteinemia will be diarrhea and ataxia. Lawrence Montbedel, it will be morbid obese one, short stature, mental retard, and polydactyly. Okay. This is the definition of retinitis pigmentosa, or nothing of all of these, isolated or non-syndromic retinitis pigmentosa. Again, it's autosomal dominant. Okay. GBS came after, Goodbasture syndrome came after transplantation. Yes, can come, yes. Again, can you repeat the finding of biopsy of thin membrane antibodies? IgA, nephropathy, vasculitis. You mean the finding for each disease? I'm not sure about Goodbasture. I think antibodies, I cannot remember the name. If you want.
The name of
Yes.
what?
Antibodies in each disease, IgA nephropathy, and Goodbasture and vasculitis.
أولاً ال IgA nephropathy is also part of IgA vasculitis. تمام؟
Yes.
هلا الترم الجديد قال لك ما في شيء اسمه هينوتشيتشولين بيربرا وما في شيء اسمه هينوتشيتشولين بيربرا only in young. Also there is يعني also there is غيروا الاسم سووا IgA vasculitis و there is
This is
pediatric presentation.
This is Berger disease, Dr. Hind, IgA nephropathy.
No. Berger disease is kind of vasculitis affecting small vessels. You will not find the IgA is very high.
No, there is Berger in the kidney, not apart from Berger of smoker. And
ايوه هاد صح اسمه برجر
yes,
صح
Berger,
عليك.
yes.
كان اسمه بيشبه اسم الفاسكولايتس لكن
Yes.
يعني I prefer انه to keep it especially they change now يعني تستخدم مصطلح IgA vasculitis. IgA vasculitis can start from IgA nephropathy and end up with a picture like هينوتشيتشولين بيربرا with abdominal pain و joint pain وراش والاشياء هي كلياتها in pediatric و in adults. Second thing, usually there is no autoantibody. There is high level, more than the normal level expected for IgA. تمام؟ there is no autoantibody. It's only a higher level of normal regarding ال IgA. تمام؟ فكل الأورجنز اللي فيها IgA اللي هي بيسموها البادي secretions الساينوفيال الابدومين لانه بتحميك لانه الاي جي اي از ان انتي بودي first line defense in بالاreas اللي exposed للenvironment.
Yes.
will remind you انه abdominal pain و joint pain all body secretion will contain a lot of IgA و part of it الكدني. الجود posture اسمه anti GPM anti glomerular basement membrane antibody. الفاسكولايتس it depend أي type of vasculitis
yes.
أنكا non أنكا usually
GPA or
أنكا و أنكا و non أنكا vasculitis.
GPA.
الجي بي اي is أنكا.
Yes.
صح أنكا فيو will see which kind of أنكا
C
have
أنكا. It will be C أنكا.
ويجنر
Yeah.
ولا شارجستروس ولا المايكرو انفيوباثيك.
Wegener C أنكا and Sargstros P أنكا. The
في
opposite.
أنكا صح.
Yes.
والمايكرو والMPA both of them positive. والبان بالعكس هو أنكا negative بس if it is present it will be B أنكا.
Yeah, less percent.
هو
أسد
الجود بس أظن ليه الجود باتشر هو أنكا نيجاتيف. ما الجود باتشر والاسم
good
No,
patcher
no
is not
أنكا.
an
Good
ANCA.
batch.
Yes, it's not an ANCA. We said it's a GPM اللي هي glomerular basement membrane autoantibody. أما vasculitis, you have to say which vasculitis.
Yes.
Because
Yes.
each vasculitis have its specific antibody. Between two brackets, general term ANCA و non-ANCA. ANCA
Okay.
positive و non-ANCA positive.
Yes, clear now. Thin basement membrane antibodies, Dr. Ahmed. My question about finding biopsy in Alport. Yes,
No,
thin
thin
basement
basement
membrane.
membrane, there is no autoantibody. Then thin basement membrane من اسمه. ال RBC are permeability of this membrane because it is thin is not a healthy permeability. ترى those patients حكم الفاميليا الهايبو إذا بتتذكروا بالهايبوكالسيميا والهايبركالسيميا عنا الفاميليا هايبركالسيميا لا بالعكس هايبوكالسيميا هايبركالسيوريا they are
Yes.
totally normal patients مع إنه في عندهم biochemical findings. Nothing in their life. The same apply for thin membrane. But when you take an electron microscopy, you will find the basement membrane تبعهم ما بين الاندوثيليوم والبومن capsule is very thin. Thin than it should be. وهذا الشيء بيخليهم عرضة for penetration of the RBC وعرضة للهيماتوريا. واللوين بين هيماتوريا هدول لا في عندهم symptom بيجوا very severe loin pain misdiagnosed as an IgA nephropathy usually وبعدين بتلاقي لا they have also some other reasons ما هي ببالي بس هدول symptomatic بيكون في عندهم loin pain بس ما في auto antibody على الأغلب يعني أغلب الظن ما في auto antibody تمام يعني I hope I'm
Yeah.
correct.
Someone mentioned Fabry disease. I think the Fabry is association of systems.
No Fabry disease is a glycogen storage disease
Yeah.
is this يعني disease مثل systemic disease affecting multiple organ الهارت
Yes.
peripheral neuropathy بيشبه كتير الرفسن بس guys Fabry disease is something if you say that in the exam يعني شوف
Yeah.
الألبورت you will not be too much showy بس إنك تقول Fabry disease in the exam يعني you are
Yeah.
putting yourself in a position
Yeah.
which يعني لا حدا يحسدك عليه.
Mm-hmm. Does it
But
make
try
sense
to
to you?
avoid Fabry disease. Fabry disease is a very advanced يعني حتى الرفسم sometimes we only mention it على استحياء بالretinitis pigmentosa. So take care of mentioning those big categories يعني.
Okay. Some Dr. Ibrahim said, don't say you have to stop. Mention I need from you to stop. Okay, yeah, for the welfare. Agree. Okay, any other concern or question?
Basim,
Yes, Dr. Ahmed, welcome back. Yes.
joined just to share reassuring.
Thank you so much, Wallahi, for your experience. And yes, here you are. The mic with you.
Even if the patient came with shortness of breath, he will target you. I'm using pillows to release my dyspnea. So
Right.
from the first sentence from the patient, he guide you away
He's
from
volunteer by that. Yes.
yeah.
Good.
Yes. So taking to cardiac reason rather than chest or anemia.
Yes. Mhm. He give you the clue, you mean, from the start.
Yeah, the only trick is the patient in AF and the drug list is not mentioned the blood thinner.
You have to ask by yourself.
Yeah, he gave you ACE inhibitors, beta blocker, but you find the regular pulse. So I asked him, "Are you in blood thinner?" He laughed and said, "Yes, I am on Abexpan." And he logged. This is the only trick in the exam. Anyway, the murmur was very, very, very clear. The most obvious murmur I ever heard of mitral regurg.
Yes, the band systolic is clear, like no
Sometimes,
doubt.
but sometimes it's very soft murmur.
If mixed maybe with mitral stenosis.
I think the examiner is trying to help not to make traps. Some of them is discriminative, definitely, but I didn't feel any problem with communications scenario. And long case scenario was fine. The problem in the abdominal examination always we don't have enough hepatosplenomegaly in UK, so they are bringing normal abdomen.
Polycyst, normal.
Sometimes normal is only as the scar, and you couldn't feel
The kidney, the
kidney.
transplanted kidney, yes.
Yes, and there is no AV fistula.
Any catheter scar
It
in the
could
neck?
be around the umbilicus, so it could be peritoneal dialysis.
Peritoneal dialysis, yes.
This is the fact. This is the abdomen. It's very strange because I didn't find any AV fistulas or lines, or just a scar around the umbilicus. It could be. It could be. It could be. Otherwise, I'm sure no hepatosplenomegaly. There's no ascites.
Yeah, I think
No.
only in Egypt and Middle East.
For the cardiology, I think aortic valve replacement was very clear. The click you can hear from the end of the bed. And second heart sound is metallic second heart sound, so it's very obvious.
Bed sternotomy scar, of course. Yes.
It's very, very, very obvious scar, and the click was very obvious. I didn't feel collapsing pulse despite the patient has Corrigan sign. So has pulse, strong carotid pulsation, but I couldn't feel any.
But he is already replaced with aortic valve.
Yeah. I said this Corrigan sign, but I couldn't elicit any collapsing sign. And the aortic valve replacement causes connective tissue diseases, bicuspid valve, rheumatic, whatever. And there's no time for further questions.
Yes, agree.
Yeah. So what else? I think the chest is challenging. Also, the examination. I couldn't finish the examination within time.
Because of steps of chest examination.
Yeah, because lymph nodes. So I include the lymph nodes in the examination while the patient is sitting. So I almost finished the lower limb when the time off. The patient came with another long case is just intermittent fever, night sweats, and just weight loss, 3 kilos over 3 weeks. No travel history, no cough, no phlegm, no signs of TB.
HIV.
HIV, I ask for all question, all negative. I ask her frankly, have you ever tested positive for HIV? I ask for all risk factor of HIV negative. I didn't feel any lymph node, but she has median sternotomy scar, aortic valve replacement.
Infective endocarditis.
So yes, I include infective endocarditis, plus I will rule out TB, plus I will rule out HIV, plus I will rule out cancer. Despite I'm not convinced with all of those, because but the story, the examination, and the question for infective endocarditis.
That's it. You catch the case, yes. Well,
so the exam is not difficult, but some vague instructions. The neuro, the patient cannot carry on his daily activity, cannot carry out his daily activity. Please examine the peripheral nervous system. What is the peripheral nervous system? This is the muscle and nerves and neuromuscular junction. I discovered it later. But I started by lower limbs. They said sensation is normal, no need for gait. So I asked the patient to walk. They said no need. So I started power tone reflexes, lower limbs, then sensation, no need for sensation. So this is motor. Then I found some deformities in the upper limbs. It's too difficult to interpret because I couldn't imagine this is muscle dystrophy. But But when I said this is lower motor neuron, this is pure motor, this is muscular, I said either neuromuscular junction or muscle. They started, how many kind of muscle dystrophy do you know? What's the most common cause? What type of muscle dystrophy you know? So this is difficult case.
I think added autosomal dominant or inherited one, you can mention the Becker, Duchenne, limb girdle.
Duchenne and Becker and facioscapular.
Limb girdle, facial.
Then the time of, because initially I couldn't interpret the signs.
Yeah, it's difficult, really. I agree.
Because the weakness is asymmetrical, bilateral. pure motor.
Yes.
I examine the lower limb and the deformity in the upper limb. So I finish the motor in the lower limb, then I start to search for the upper limb.
Suppose the gate will be also waddling gate. I don't know.
They didn't allow me to do gate, but I
Yeah,
asked for
but
it.
yeah, it will be there. But they want to hide. If you know the
No,
gate.
I think the patient unable to walk, and
Okay.
we have 3 cycles of candidates, so 15 candidate for today
Yeah.
examination.
So he feel weakness. So if you
Yeah. So for welfare, they ask no, but anyway, if you ask for it, they will mark it to you.
Yes, of
The
course.
problem is peripheral nervous system make me
Peripheral nervous system, any route after the route, as you said, anterior horn and after that. So including even the cranial nerve.
yes,
You
but
can offer
but
cranial nerve.
for a while.
Yeah, maybe
if you
because of the first time. Yes.
block peripheral nervous system.
At least, Dr. Ahmed, you help us and you guide us. What should we do?
So I
Because
started. The examiner
yeah.
was guiding because when they said normal sensation, no need to do sensation.
Yeah. So yeah, they are guiding you what to do.
But you have to examine cranial nerve, Ahmed. Cranial nerves.
No time for cranial nerves.
7.
Or offer. I
7.
would like to do. Yeah.
Yes, 7 and 12.
In the surprise of the exam, just carry on.
Yes.
Do the task peripheral nervous system. What is the cranial nerves will do in the peripheral nervous system?
Yes,
They keep saying no. They keep saying I think facial asymmetry.
Facial
Yes.
asymmetry.
Only by inspection, not cranial nerve
And
asymmetry.
facioscapulohumeral
Yeah.
dystrophy,
Facial
facial
scapular,
is
yes.
important. Yes.
The problem is I have some sort of mental block. Then I overcome it to try to manage.
But guys, when you will mention face, you will not mention facial nerve, you will mention facial muscles. It will be part of the muscular system mentioned by Dr. Ahmed. يعني always differentiate between facial weakness due to facial nerve palsy or facial weakness due to myopathy.
Yes.
Sometimes offering something you are right, but you mention it in a wrong way. If I will mention the face, I will mention I would like to examine facial muscles, not facial nerve.
Yes.
Facial nerve, you are against the command.
I told the face, not cranial nerve. I didn't
Yes,
mention cranial.
Yes.
Because
يعني it's just like facial muscles أو face. يعني إذا الواحد عن جد stressed خلاص I want to examine the face.
لا الموضوع مش I think is in case of you face unexpected kind of examination.
What about the accessory nerve?
I think no time to do anything, just to check. Because you start on the lower limb, you consume time in lower limb because you don't know how to examine peripheral nervous system.
Winging scapula you did?
No. I just done lower limbs and upper limbs and the time is off. No time for this.
Yes, agree.
No time.
At least you give us idea about this possibility, so we will be ready with this. But winging scapula will be one of the diagnostic.
If you have time, do it. But I think because this is the first time.
Because you were stuck, Dr. Ahmed. But if you think as a muscular dystrophy, you will do it. But because of you are starting to do testing for the sensation, you waste sometimes the sensation. But if you focus,
Dr. Bassem, I suddenly found myself. How can I examine the peripheral nervous system?
Yes, I agree. But it will not be away from what we are doing. Peripheral nerve as lower limb and upper limb. It will be around the same.
What helped me? The patient is very weak.
Tone, power, reflex, sensation, coordination.
Very weak distally. So the ankle, muscle around the ankle is very weak. There's deformity in the upper limb. So assume this is long-standing muscular disorder. This is what helped me. Otherwise, nothing. I am not expecting muscle dystrophy.
What were the questions of the examiner?
What's your finding? So they didn't ask what is the diagnosis? What's your finding? So hyporeflexic.
This is the most important. Upper or lower motor neuron. That's it.
I said lower motor neuron.
Yeah, this is what they need.
But only he asked this, no investigation, no management plan.
No. You will go through how you diagnose the patient. So you will go through this.
They said I told everything, then EMG, muscle biopsy, genetic testing.
CK and Yes.
But anyway, it's a difficult scenario because your peripheral nervous system is not usual request to examine.
Practice. Yes. Yes.
So I don't know what the peripheral nervous system means. Then after exam, I found, yeah, this is nerve. I assume initially this is peripheral neuropathy. Then I very surprised when she said the normal sensation. What does it mean? So what's this? So I said neuromuscular or muscle. Yeah.
I think I did not know the detail. I think this is a facioscapulohumeral dystrophy because this is mostly in the peripheral nervous system, which comes.
I think it's Duchenne because the patient is very, very weak and there's wheelchair.
Cachectic. He's cachectic also?
Yes, yes. And they ask what's the most common cause of death, which is cardiomyopathy.
Respiratory failure.
Yeah.
Cardiomyopathy or respiratory failure?
Cardiomyopathy.
Okay. Yes.
So I think it's Duchenne or Duchenne.
Becker. I think Becker, he's the one.
The calf muscle is atrophied, not hypertrophied. So I don't think it's Becker. It's just Duchenne or there's another one.
But Becker live longer than Duchenne. Duchenne die early.
Yes.
I don't know about this. It's a very severe.
At least you mentioned both of them, right?
Yeah, I mentioned the differential diagnosis.
That's
how to diagnose,
enough.
what is the complications, is the time off.
Fair enough. I guess you will pass this station.
I hope so, but the overall pass or not pass, it's not a matter.
Inshallah, you will pass.
I think my performance is much better than the first attempt.
Don't judge, but hopefully you will pass, inshallah.
Yeah. So I'm happy from the exam regardless the results, because actually my initial trial was very bad for performance. Yeah, no, my performance was very bad. I was very stressed. I didn't say anything in the abdominal station in my first attempt.
You are mature more than before, Dr. Ahmed.
Now, no, I didn't look at the examiner at all. Even in the communication, I don't know the faces of the examiners. I didn't look at them at all. I focused.
Perfect.
This is the advice from Dr. Mahmoud.
Yes, because they will distract you. They will distract and distress you.
No, I didn't look at them at all. I just focus on the patient. The
surrogate or patient, yes.
Surrogate. Surrogate is very kind man. So yeah, it was fine. He didn't argue with me.
Alhamdulillah. Thank you, Dr. Ahmed. Best of luck. Inshallah, you do it this time.
Hopefully.
Inshallah. Thank you for the experience, Dr. Ahmed. Okay, bye-bye. Okay, any question else from others? Dr. Hind, excuse me, tomorrow after communication it will be shorter than the session will be shorter.
عادي يعني I will try to be بس الله يوفقك لو ما كنت موجودة وعن جد كان بيناسبكم عادي بس ابعت لي مسج yes I will join لأنه يعني أنتوا حتكونوا عملتوا لي معروف فالمفروض أنا خلص بإذن الله بدخل وبسمع معكم.
Okay, doctor. Okay.
تمام.
Okay. Thank you so much, Dr. Hind. Thank you, Dr. Ahmed. Thank you, Dr. Abminam, also for practicing with me today. Any question? Communication, what cases? It's in the group, Dr. Ahmed. He sent it in the group. Communication scenarios. All the experience he shared it to us. Okay, I will mention it again. Okay, because of the late time, I would like to end this session. Thank you for sharing with me this session today, practicing and commenting. See you tomorrow, inshallah, with Communication Day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Ibrahim.